This is my perio project by Riley Cregan. The initial lesion stage is 2 to 4 days after biofilm accumulation. It's the cellular host response to the microbial challenge when dental plaque begins to accumulate at the gingival margin and microbial agents trigger an innate immune response. Neutrophils, also known as PMNS, are the first immune cells to recruit to the site through the junctional epithelium, and they move towards the plaque. Cytokines are released by the neutrophils, and they amplify the immune response. IL-8 specifically acts as a chemoattractant to draw the neutrophils towards the area accumulating with biofilm. MMPs, particularly MMP8 and MMP9, are released by neutrophils to degrade extracellular matrix components, helping to clear the pathogen but also contributing into tissue breakdown in the future. Tissue damage. Plaque is supragingival as of right now, and the gingival cervicular fluid increases in its volume. Clinical signs observed by the RDH are healthy-looking tissue, slight marginal redness may be seen in some patients, and no BOPs, bleeding on probing. Most changes are microscopic at this stage as well. Looking at the outcomes of the host response, in these early stages, if the microbial challenge is removed by oral hygiene, the host response resolves and the tissue returns to a healthy state without permanent damage. But if the biofilm continues to persist, it may turn into the process of the next stage, the early lesion stage. The early lesion stage is 4 to 7 days after plaque accumulation. The cellular host response, as bacteria continue to accumulate, particularly gram-negative in the immune system, activates an inflammatory response. Neutrophils, or PMNS, dominate the site. Destruction of the connective tissue happens. Macrophages and lymphocytes begin to infiltrate the area, and cytokines like IL-1B, TNFA, and IL-6 are released, signaling to amplify the immune response. PGE2 is another immune cell to help the infection site. T lymphocytes then are released, and they release cytokines and antibodies to help the immune response. The MMPs, specifically MMP8 and MMP9, are secreted by neutrophils, leading to degradation of collagen in the gingival connective tissue. The tissue damage. Circular epithelium and connective tissue are 60 to 70% of collagen loss due to the MMPs, especially MMP8 and MMP9, due to their activity. The increased permeability of blood vessels due to the inflammation, leading to more fluid, and the immune cells in the tissue amplify. Early lesion stage clinical signs observed by the RDH, such as redness and swelling due to the increase of blood flow and vascular permeability. The bleeding on probing is a key indication of active inflammation. No significant loss of attachment. It's still considered gingivitis at this stage, and possible gingival tenderness when brushing or probing. Early lesion stage outcome of host response. If the inflammation resolves with good oral hygiene care, but also with tissue repair with the collagen, gingival health is restored. But if it persists with the biofilm, more immune cells infiltrate the tissue and the risk of future periodontitis increases. Established lesion stage is the next stage if this continues to persist. Established lesion stage is 2 to 3 weeks after plaque accumulation, no longer acute gingivitis, and this is now chronic. More cytokines lead to PMNS and macrophages and lymphocytes are recruited. Over 50% are plasma cells, leukocytes, that produce antibodies. The MMPs are active in collagen and break down the connective tissue damage. The epithelial ridges extend deeper in the connective tissue. The junctional epithelium loses its attachment. Continuation of the collagen loss in the connective tissue zone and junctional epithelium moves apically in preparation for future pocketing and formation in later stages. Established lesion stages, clinical signs as observed by the RDH. Gingivitis established by day 21 after biofilm accumulation is the most prominent then. Redness and swelling are also a key sign of inflammation. Bleeding on probing can be seen more readily in this stage, and bleeding gums are also noticed by patient, and this can happen when brushing. Gum sensitivity also sometimes occurs in most patients. Established lesion stain outcome of the host response. If inflammation resolves with a good oral hygiene care and patient is now educated and professionally treated in the clinic, you can get this type of inflammation under control with continuing good oral hygiene care. But if the inflammation persists, biofilm isn't controlled, it can either stay at established gingivitis, but there is a huge risk for developing future periodontitis. But it might never progress to periodontitis, but it's best to get this condition under control so that it does not develop into periodontitis in the future. This is the advanced lesion stage or periodontitis. A host response indicates the bacterial infection is now chronic and immune system is so intense that it's harming the periodontium. The PMNS macrophages cytokines cause destruction of gingival connective tissue and PDL. PGE and MMPS also cause destruction to connective tissue and alveolar bone. PGE starts bone destruction by stimulating large numbers of osteoclasts, which help break down the bone. But then there's osteoblasts that build up the bone. But osteoclasts are breaking it down so much that they are resorbing the alveolar bone, leading to permanent bone destruction. The tissue destruction is caused by an overwhelming host immune response that is overwhelming for the host, and it's unable to repair the damage that is caused. Advanced lesion tissue damage. Junctional epithelium moves apically and resulting of a development of the periodontal pocket. Favors destruction of the gingival connective tissue and PDL. Osteoclasts constantly destroy the bone, leading to the bone loss that is not reversible. The advanced lesion stage. Clinical signs observed by the RDH. Periodontal pocketing can be seen in clinic with a 4 mm probing to a 12 mm probing. Bleeding on probing is seen more commonly. Bone loss is seen on radiographs or could even be seen clinically. Furcation involvement between the teeth and tooth mobility is also seen. Advanced lesion outcome of the host response. Irreversible tissue damage is a hallmark of periodontitis. Once a perio patient, always a perio patient. But that doesn't mean we cannot get to a state where the perio isn't progressing. Description of periodontal pathogens. P. gingivalis is a gram-negative pathogen, and its role in perio produces virtuous factors, degrades tissue, evades immune response. T. forsythia is a gram-negative, produces enzymes that destroy tissues but also alerts the host response. T. denticola is a gram-negative, invades the tissue, produces enzymes, and degrades periodontal ligament. These are all read in the chart, so these are heavily influencing in perio. Some other ones are Phasobacterium nucleatum is a gram-negative, promotes plaque maturation and inflammation. P. intermedia is a gram-negative, inflammation triggering that works alongside with P. gingivalis and T. forsythia. Some risk factors that increase your chance of getting periodontitis. If you do any of these, it could increase the chances that you get perio. Smoking impairs blood flow and increases plaque and calculus, and it slows down healing. Diabetes also promotes chronic inflammation, and if it's not controlled, it worsens your chances of getting periodontal disease. Poor oral hygiene also increases the plaque accumulation without the active removal of brushing. It promotes calculus to continue and build faster upon the already continuing growth of biofilm. Stress is also a huge factor of getting periodontitis if it's not controlled or you're under a lot of stress a lot of the time. It weakens your immune response, so your immune system is constantly down. It can lead to poor oral hygiene habits in general. It may degrade you from brushing your teeth at night or in the morning and get you off track of your oral hygiene care. And that is my presentation.